hydroxychloroquine, and that's exactly what I've done. And I've found a study from Belgium that gives fairly strong evidence, in fact I would say quite strong evidence, that low-dose hydroxychloroquine is an effective treatment. It is an effective treatment. And it seems to lower the death rate by about 30%. Quite profound difference. And the key seems to be that they used a much lower dose than the other studies. Now, I am going to tell you briefly about 3 other studies as well that showed efficacy, that showed hydroxychloroquine does seem to be an effective treatment. But then we'll think about why studies have shown that it's not, and we'll talk about the recovery trial from the Centre of Oxford-based Medicine, which showed no effect and discontinued it from the trial, and we'll talk about the World Health Organization's Solidarity trial, which did much the same thing, discontinued from the trial. And then, as time permits, we'll have a look at a study from Brazil as well, which shows no effect. But it seems the key factor that people have been getting wrong, and I'm just coming to the end of the bottom line now, just stick with me if you want the bottom line. The key factor seems to be that these studies gave too high a dose. Now, let's clarify what we're talking about here. We're talking about the World Health Organization, and we're talking about the Oxford Centre for Evidence-Based Medicine. They didn't seem to realise you had to give the right dose. Now, this is bemusing at best. Now, is hydroxychloroquine a new drug? No, we've been using hydroxychloroquine and its predecessor, chloroquine, for decades, absolutely decades, for many conditions. So it's not a new drug. This is a drug that's known. The side effects are known. The doses are well known. And yet the World Health Organization and the Centre for Evidence-Based Medicine at Oxford seem to get it wrong. What is going on here? This is bemusing. You know, there's quite a few things in this pandemic, and you just can't work out why people didn't seem to realise things or get things so wrong. Let me just give you evidence for that before I finish the bottom line, before I go into the detail. For those of you who don't have enough time for this video. Now, I've just taken this morning from the British National Formulary. Now, this is what all doctors and nurse prescribers and pharmacists in the UK use. It's absolutely standard. Hydroxychloroquine sulfate, indications and dose. Right, so DOSE, dose. There's nothing hidden here. This is just obvious stuff. And if we look at it, we see that the normal dose is 200 to 400 milligrams daily. Daily maximum dose to be based on ideal body weight. Okay, so there's the dose. For most adults, 200 to 400 milligrams. This is absolutely standard public domain information. And yet, both of the studies that we're going to look at, the UK study and the World Health Organization study, didn't seem to realise this. So it's all very strange. Anyway, so that's the bottom line. If you want to skip this video, fine. That's good. Azithromycin has been used sometimes because it's got in vitro in the bench, it's got antiviral properties and it's got immunomodulating properties as well. That's why it's sometimes been used. But of course, remember, the Dutch study was not using erythromycin, it was just using hydroxychloroquine as a monotherapy. And of course, the reason hydroxychloroquine is used is because it's got these in vitro antiviral effects as well. So the theory for hydroxychloroquine and the theory for azithromycin are both good. The theory is there. Treatment alone with hydroxychloroquine and in combination with azithromycin was associated with reduced mortality. So that was saying giving the hydroxychloroquine alone as a monotherapy or giving it in combination with the azithromycin, with both associated with reduced mortality. So quite a few studies there on the efficacy of low-dose hydroxychloroquine. Now, how did we get to this state where hydroxychloroquine has been virtually dismissed? Well, the recovery trial was one. And at the time, this looked pretty convincing because this is from the Oxford Centre for Evidence-Based Medicine. This is not some Mickey Mouse organisation. But as we looked at, they were giving on this trial 800 milligrams, 800 milligrams, 800 milligrams, 400 milligrams. So on this trial, they were giving, 16, 17, 18, 19, 20. They were giving 2,000 milligrams in the first 12 hours. Let me say that again. On the recovery trial, they were giving 2,000 milligrams in the first 12 hours. The recommended dose is a maximum of 200 to 400 milligrams. Yeah. So, just briefly, this trial, we did look at this in detail at the time. Now, the numbers look good, and indeed the numbers are good. The hydroxychloroquine group got that many people. The control group got well over 3,000. So good numbers. Look it up here. It's all still there. It's all documented. Patients allocated to the hydroxychloroquine sulfate group, we got that fairly high dose, and that came out to 9,200 milligrams over 10 days. So much larger dose than the Belgium study, much larger dose than the British National Formulary tell doctors to prescribe. And the conclusion from the recovery trial was, of course, that it didn't work and it was discontinued. In fact, it was associated with an increased length of hospital stay, but of course, it looks like they were giving way too much. WHO-led Solidarity trial, again giving very high doses, 9,600 milligrams over 10 days, and WHO dropped it as well. Didn't do further research on it because they said it provided no benefit in hospitalised patients with COVID-19. So what you could really call the two most reputable research bodies arguably in the world Health Organization-led effort and the Oxford Centre for Evidence-Based Medicine Centre, seemed to get the dose wrong. Now, for the sake of balance, so let me just say, my working conclusion now is that the low-dose hydroxychloroquine has efficacy based on the Belgium data. That seems to be what it's saying. But for balance, what I want to do is give you another recent study published just in July. Remember, the Belgium study was published just on the 24th of August. That's bang up to date. But this is another study. Let's look at this one, and then we'll finish for today. Hydroxychloroquine with or without azithromycin, mild to moderate COVID-19 again, and this was in New English Journal of Medicine based on work done in Brazil. Now, this was a smaller scale study. 55 hospitals in Brazil. It was randomised, that's good. It was open label. Now, what does open label mean? Well, very often in clinical trials, we like them to be blind. Now, in a blind trial, the person getting the medicine and the person prescribing the medicine doesn't know that they're getting the medicine, or they don't know whether they're getting the medicine or whether they're getting a placebo. I did this in a study when I was a young staff nurse on coronary care, way back in it was a long time ago, 1988, I think it was. It was called the International Study for Infarct Survival. And we were working out whether this drug called streptokinase and streptokinase in combination with aspirin, which is a clot-busting drug, would work. So people would agree to come on the trial. So we would say to the people coming on the trial, come on the trial and we'll give you the best available treatment. That's guaranteed. But there's a 50% chance you'll get this new treatment as well, which did turn out to be brilliant, by the way. The clot-busting drugs, the thrombolytic drugs, have absolutely revolutionised coronary care. So, if I was coming in with a heart attack, you'd say to me, well, you get the best treatment we've got, or there's a 50% chance you'll get this extra treatment. So most people obviously went on the trial. And then what happened was we went to a box, and we had the bags of fluid, because we gave it as intravenous bags of fluid, and it had a number on it, and we didn't know whether it was the active thrombolytic ingredient or whether it was the a bag of salty water, and we just gave it and we recorded everything, and it was only the people that had the codes to that would know. So me, as the person giving it, the doctors prescribing it and the patient receiving it, none of us knew whether they were giving the active thrombolytic ingredient or whether they were giving a bag of salty water. We didn't know. That's blind. But this wasn't like that. This was open label. And obviously blind is better, but this was an open label one, so the prescribers and the patients knew what they were getting. But they did have 3 groups and it was controlled. Now, notice here, and this is the trouble with quite a few of these trials, they're actually based, if you're doing a trial, it's actually quite a lot of work. It's a lot of work. So, recruiting 670 patients is quite a lot. The last research study I did, I don't do much research now, but I did this research study and I recruited students from the UK, Hong Kong, Cambodia and Kenya, and I wanted to compare the efficacy of educational interventions in these different cultures, trying out the same educational intervention in different cultures. And I think I recruited about 600 patients altogether. But I tell you what, that took some doing. That involved trips to Cambodia and trips to Kenya. I mean, I was teaching there anyway. But it involved a lot of travel, a lot of work. Okay, I didn't have a team. It was just me and people in the institutions there that were kind enough to help me. But recruiting 600 patients, 600 students in my case, was a lot of work. So for a study to recruit 667 isn't too bad. But remember, we're much more likely to get valid data from the larger numbers. And the Belgian study had 8,075. So the Belgian study had many more patients. Therefore, the validity of the data that we're likely to get from the Belgian study is likely to be much better. It's likely to be more valid. Anyway, let's keep going. 504 patients confirmed with COVID. Now, these were patients who weren't very ill again. They weren't the sickest patients. They're receiving no supplementary oxygen or a maximum of 4 litres per minute. Now, 4 litres per minute is a lowish dose. Typically at work would start patients off on 2 litres per minute. That would be the lowest dose that you can give realistically, actually. Very often give that with a nasal cannula, but 4 litres per minute would be a relatively modest dose of oxygen, a relatively modest amount. So these weren't the sickest patients they were dealing with here. And they had 3 groups, 1-to-1-to-1. Standard care group, they recruited 229. Standard care plus hydroxychloroquine, that's the second group. So that's the first group, standard care. That's the control group, really. Standard care plus hydroxychloroquine, 400 milligrams twice daily. So a bit of a higher dose than the bit of a higher dose than the Dutch study, because that gave 400 milligrams on the first day, then only 200 milligrams twice daily after that. So a bit of a higher dose. 221 patients, and then standard care plus hydroxychloroquine, 400 milligrams twice a day, plus azithromycin as well, which, as we said, is known to have probable antiviral and immunomodulating effects. Because remember, we don't want the immune system to get out of control, because that's what causes the acute respiratory distress syndrome, causing the alveoli to fill up with fluid, as you know if you've watched these videos before. Now the results in this Brazilian study, no difference in the need for ventilation, no difference in the deaths, no difference in the thrombolytic complications, that's the little blood clots that form in the blood vessels, no difference in the number of people getting acute kidney injury, that's acute renal failure. So they found no difference between these 3 groups. But it's a much smaller scale study. It's only 667, not over 8,000 patients. Having said that, you would expect to see something, but you didn't. Is there a contradiction here? Yeah, there does appear to be a contradiction here. They examined the clinical status after 15 days. Standard care was measured at 1. Hydroxychloroquine alone, patients got 21% more. They got a 21% higher scale on the adjudication scale that they were using to monitor how the patients had done, and the higher the number, the worse the outcome on their scale. So that they were 21% 21% more likely to do badly. So the hydroxychloroquine alone was having a negative effect, and the hydroxychloroquine plus azithromycin, their hazard ratio was 99, which means there was a 1% reduction in poor outcomes. So, but the big but is neither of these were significant. You know, it's only when you reach the 95% significant value that, so they can be ignored basically. It's not significant data. It's not significant data. I remember when I was doing my, I did a biology degree, and I did this really complicated study on different things, and it was comparing one group against another group, and you know, there was nearly a change in every group, but it wasn't quite at the 95% level, so it was really confusing. So I argued this, and I got the assignment back, and like in big red letters all over it, the examiner said, "Do not argue from non-significant data. Do not argue from non-significant data." In other words, if it's less than 95% likely, less than 95% chance there's a genuine difference, we have to assume there's no difference at all. So very frustrating for researchers, but if it doesn't reach significance, the result's not significant by definition. It's no good. And these didn't reach significance. And in this study in Brazil, they did find prolongation of the corrected QT interval. Now, this is often talked about with hydroxychloroquine with large doses. This is why it's so important to give the right dose, because it's quite toxic. Hydroxychloroquine and hydroxychloroquine are quite toxic in higher doses. If you give higher doses, there's a chance of heart not beating properly, what we call cardiac dysrhythmias. And a lot of people call them arrhythmias, but really they're dysrhythmias. And fitting is another possibility. So what they found, and several studies have shown that prolongation of the QT interval. So I'll tell you what this is. So in a normal heart wave, you have the P wave. The P wave is the contraction of the atrial myocardium. Then you have the Q, R, and S like that, and then you have the T wave. So that's a normal heart rhythm. So P, that's the Q down there. That's the R. P, Q, R. That's the S, and that's the T wave. So that's the normal heart wave. So that's the top chambers contracting. That's the bottom chambers contracting, and that's the bottom chambers electrically going back to normal, process called repolarization. So what these studies found was prolongation of the QT interval. So that's the Q there, that's the T there. In other words, that interval was prolonged, indicating usually there's trouble with the conduction of electrical impulses through the heart. And of course, if that's messed around with too much, the heart will not be beating properly, and it will potentially you can go into cardiac arrest. That's of course why we have to give the right dose. So there was slightly more of this in the Brazil study, but of course they were giving a fairly high dose. They were giving 400 milligrams on day 2, on day 3,